Hello, everyone. Welcome to Asian Cancer Resource Support Services Health Talk for the month of November. My name is Sienna Fong, and I am the Cantonese and Mandarin speaking Cantonese patient navigator with the Asian Cancer Resource and Support Services, or ACRSS for short. Before we get started, I would like to give you a brief overview of what ACRSS is. ACRSS is the first ever Asian Cancer Resource Center in Oregon that aims to address the full cancer continuum, ranging from prevention, screening, treatment, to survivorship support. We serve clients in Cantonese, Mandarin, Korean, Vietnamese, and English. Our goal is to increase the culturally and linguistically appropriate cancer resources, educational material, and support services. To learn more about the specific types of services, please contact us through phone or email. You may also visit our website to view or download our brochures and flyers to share with your friends and community. A link to our website will be added to the chat box. Lastly, there are a few housekeeping items that we would like to go over with everyone. The presentation today will be recorded. We kindly ask that you turn off your microphone and camera to reduce background disturbance during the presentation. Because of this, we suggest you type any questions you may have during the presentation in the chat box. We will gather all questions and have a Q&A session at the end of the presentation. Please note we will stop the recording once the Q&A portion begins, and you will be unmuted to present your questions. This presentation will be shared on our AHSC YouTube channel as educational material, so if you're interested in viewing the PowerPoint slides again, please find the recording on our YouTube channel. With that being said, please help me welcome today's presenter, Dr. David Chen. First, here is a short bio of Dr. David Chen, but we'll also be now showing a YouTube video to introduce him.
Hi, I'm Dr. David Chen. I'm a thoracic surgeon here at Providence Cancer Institute. I'd like patients to know that when they come to me for care that I'll prioritize them as a human being first and foremost, and then I'll listen to their needs. In addition, I perform robotic thoracic surgery. This is a form of minimally invasive surgery which allows me as the operating surgeon to have complete precision and control over the conduct of the operation and allows me to see in high definition. All this altogether, I think, provides high quality care for our patients. In addition to my responsibilities as a surgeon, I'm also a scientist here at the Charles Research Institute. I'm investigating immunotherapy in lung cancer, and that means harnessing the immune system to fight cancer. More specifically, my investigation involves studying cellular therapy towards lung cancer, which is having a patient's own T cells fight the cancer. What inspires me about my work is that in modern medicine, despite all the advances that we've made, especially in oncology, there's still so much that we don't know. But that's why we're here to learn and to work to improve outcomes for patients and their families. I love to enjoy food. That includes eating and cooking, but more so eating, I think.
What a wonderful video, but please help me welcome Dr. David Chen.
Sienna, thank you for that kind introduction, and thank you to the Asian Health Services Center for inviting me today. It is Lung Cancer Awareness Month, so it's timely to discuss the latest updates in lung cancer care along the spectrum. So let me put up my presentation here. Great. I think I have it up correctly. Let me know if there's any technical issues. So the title of today's discussion is What is New in Screening, Prevention, and Treatment of Lung Cancer? I am a thoracic surgeon here at the Providence Cancer Institute in Portland. I do not have any disclosures for today. This is the agenda that we'll be discussing. First is an overview of lung cancer. We'll discuss risk reduction strategies, screening updates and recommendations, overview of treatment and clinical trials that are contemporary and relevant today in 2023, and then have time for questions and question and answer session following that. So an overview of lung cancer. First and foremost, lung cancer starts in the cells lining the inside of the lung, including the airways. That includes the bronchi and the air sacs or the alveoli. So a brief anatomy review, you can focus on the diagram on the right. As air moves through our respiratory system, it enters beginning through our mouth up top, travels down the windpipe, more commonly known, or as we call the trachea, down the middle, and splits into the left and right lungs, beginning with the bronchi. So the airway is called the trachea at the top and the middle, and then it separates into the left and right mainstem bronchi. As the air travels even further, it goes into what are called bronchioles, or you can think of them as little bronchi, and then eventually into the alveoli or the air sacs, and that lines the outside or the periphery of the lung. And this is where the gas exchange occurs. When you breathe oxygen, it dissolves from the air into the bloodstream, and then we exhale carbon dioxide from the bloodstream back into the air sacs, and then the gas follows the reverse pattern going out of our airways. We'll also review statistics on lung cancer, different types of lung cancer, and contributory risk factors as well. These are updated statistics of cancers in the United States from the American Cancer Society. As you can see, this is current as of 2023. On the top, you'll find estimated new cancer cases in the United States in 2023, divided between genders of male and female on the left and the right, respectively. The highest incidence of new cancer cases in males remains prostate cancer. On the other hand, in females, it remains to be breast cancer, on the order of about 200 to 300,000 total cases in the United States. And this encompasses about 30% of new diagnoses of cancer. Coming in at second for both genders are lung and bronchus cancers, on the order of about 120,000 new cases per year. And this accounts for about 12 or 13% in total. If you shift down to the bottom of the screen, this shows the number of deaths attributed specifically to cancer in 2023. And for both genders, and this has been for quite some time, deaths related to cancer are caused specifically by lung and bronchus cancer. It's the #1 cancer killer in the United States. And this is on the order of 60 to 70,000, and this accounts for about 20% of deaths related to cancer. So this all goes to show altogether that lung cancer is highly prevalent. It's important to recognize, diagnose, and treat, and to discuss, and it's certainly not going away anytime soon. It impacts everyone, whether it's the patient primarily or friends and family. Someone you know may also suffer from this disease, so it's certainly important. A little bit more on statistics. This is a little bit older, if you see at the bottom, from 2016 to 2020. This is from the SEER database, which is one of the largest databases that we use, sponsored by the federal government. And similarly, on the left, you'll see rates of new cases per 100,000. And on the right, you'll see deaths due to lung cancer per 100,000. And this is different than the last slide because it categorizes these statistics based on race and ethnicity. So if you focus on the left, again, on the left hand column, you'll see male versus female on the right hand column. And again, this is rate of new cases of lung and bronchus cancer per 100,000 people. On the top row, you'll see all races. So that would be either 56 or 45 cases per 100,000 persons. Admittedly, this diagram is a little bit confusing because I would think that if you look at all the subcategories of races below, that these would all add up to the top row. Somehow that's not the case, but irrespective of that, what this shows you, the bottom line is that there's differences in rate of new cases of lung cancer if you subcategorize based on ethnicity. And for example, you can see that the lowest rate of lung cancer, if you categorize based on these ethnicities, is in the Hispanic population at about 20 to 30%. On the higher end, on the other hand, non-Hispanic Blacks have a higher incidence, particularly in males, at about 68%. If you look at non-Hispanic Asian Pacific Islanders, it's somewhere in the middle. But the point being overall is that while there are varying differences and degrees of incidence amongst all these races and ethnicities, no one is immune to being at risk for lung cancer. On the other hand, if you look on the right-hand side, again, this is deaths per 100,000 due to lung cancer, and you can see, once again, the point being is that there's differences in race and ethnicity, but certainly we all have to recognize and be aware of our risk for lung cancer altogether, no matter which race you are. So some more statistics. The second most common, again, this is a recap, the second most common lung cancer, or most common cancer in both men and women in the US is lung cancer. The leading cause of cancer death in the US is lung cancer as well. And each year, more people die of lung cancer than of colon, breast, and prostate cancers combined. Another way of looking at all of this is 1 in 16 men and 1 in 17 women will develop lung cancer during their lifetime. And this includes both smokers and non-smokers. Approximately 80% of lung cancers are caused by cigarette smoking. So there's obviously always been an association with cigarette smoking, but it doesn't always necessarily mean that all lung cancers are caused by smoking. There are many, many non-smokers that have lung cancer. In particular, too, of note, the risk of lung cancer is greater in persons with lower socioeconomic status. They're more likely to be diagnosed with advanced stage disease and lack access to high quality cancer care. So this is important to note because it affects people in terms of their risk for getting lung cancer prior to diagnosis, and after diagnosis, it also affects their ability to have access to treatment. So across the whole spectrum of cancer care, it impacts on both sides, and that's important to note. One other aspect to note is age. Although lung cancer is not common in young people, it does occur. It's missed in the early stages often. So you should tell your healthcare provider if you have any signs or symptoms of lung cancer, if you have a family history of disease. And there's a link, as you can see here, if you get the slides after, where you can see what these signs or symptoms are. Now, it's important to note, like many cancers, not only lung cancer, but many cancers, when there are signs and symptoms, it's unfortunately often a diagnosis at later stage of disease. So these are things like weight loss and fatigue and a general feeling of unwellness. But if you have any signs, for example, of cough, difficulty breathing or wheezing, that may indicate an earlier stage in general, but these are not specific and and concrete signs or symptoms. Altogether, it can be diagnosed at an earlier stage versus a later stage with any of those signs or symptoms. That is all to say, if you have any signs or symptoms or you have any of these risk factors, you should certainly make a note of it to your primary care provider, just so that everyone is being vigilant and alert to the possibility of lung cancer. So we'll discuss types of lung cancer, and we'll try to keep it relatively simple overall. We break them down, generally speaking, into two main types of lung cancer, and that is small cell and non-small cell. And you might wonder, we kind of throw these terms around, as you might hear often in the media and so on and so forth. Why do we say non-small cell lung cancer? Well, it's because small cell has a particularly worse prognosis. It is more aggressive and it's harder to treat. So we make the distinction because if it's small cell, that immediately tells us it acts differently, it behaves a little bit more aggressively, whereas non-small cell does not act like that, and the treatment decisions tend to be different. If we want to get into a little bit more detail, there's some subcategories beyond these major categories. A small cell is generally pretty simple. You can also have a combined small cell, which means it has features of other types of cancers, but in and of itself, that's the main differentiator. On the other hand, non-small cell consists of multiple types of non-small cell lung cancer, and that is adenocarcinoma, squamous cell carcinoma. Those are the two most common types of non-small cell that we deal with. And when you're talking about lung cancer that's attributed to smoking, these are oftentimes associated, but again, it does not have to be related to smoking. There are definitely non-smokers that get these types of cancers. You might see on the right large cell carcinoma, and there are other types that are not listed here, for example, carcinoids. And those are even subdivided further because we love to categorize things, but those can be atypical and typical carcinoids. And even to note, these carcinoids, the large cell carcinomas and the small cell carcinomas, are actually all along a spectrum of a similar type of specific type of cancer. But that's getting a little bit in the details. For now, this is a good structure to just understand in simple terms. Now below, you'll see another way of looking at these types of cancers, which is the frequency of everything that I just mentioned a moment ago. So you'll see in the pie chart, small cell lung carcinoma consists of about 15% of diagnosed lung cancers. So not a majority by any means, but more aggressive, again, in general. On the other hand, the biggest piece of the pie is the blue piece, which is adenocarcinoma, which represents about 40% of lung cancers as of today, and 30% consisting of squamous cell cancers. Historically, the diagnosis has been more so in the past squamous cell carcinomas, but it certainly has shifted more to adenocarcinomas as of late. These are some microscopic slides showing the differences of the two more common non-small cell lung cancers, that is squamous cell carcinoma and adenocarcinoma. On the left, you'll see normal cells for each type. If you see on the top, this is normal epithelium. Now, I will say that generally squamous cell carcinomas tend to appear more in the beginning of the airway, as I mentioned in one of the earlier slides. That is more of the bronchus and the bigger airways, whereas adenocarcinoma is a cancer of the glandular cells in the airways, and that tends to be present in the ends of the airways, or the outside, or the air sacs that we discussed a moment ago. And so that's why, generally speaking, squamous cell carcinomas will appear in the center of this whole respiratory tree, where the bronchi and the bronchioles are, whereas adenocarcinoma tends to appear more on the periphery or the outside because of the lungs, because that's where the air sacs lie and the glandular cells lie. So on the upper left, you'll see normal normal cells there, lining the bronchus, for example. In the middle, top, you'll see carcinoma in situ. So carcinoma means it is cancer or tumor cells. In situ means that it has not invaded any layers. So invasiveness is a marker of aggressiveness of the cancer, and it has to invade beyond a layer called the basement membrane. And that's a slide you'll see in the upper right, which is invasive carcinoma. And this is different than the carcinoma in situ because it has invaded that basement layer of the tissue. That's important to note because when you hear terms like metastasis or spread through to the lymph nodes or the blood, this is exactly where that's coming from. Because when it invades layers, it can invade lymph nodes and blood vessels and spread beyond the area of the lung itself. If you shift to the lower row, you'll see examples of normal lung or normal air sacs in the lower left, and then adenocarcinoma lipidic pattern here. So this is equivalent to the in situ as you see above. This has gone through a number of changes over the years in terms of terminology, but adenocarcinoma in situ is the same as adenocarcinoma lipidic spread pattern. And this means that, again, you can kind of see here the air sacs, and the tumor spreads along the lining of the air sacs without invading the borders of the air sacs. On the contrary, on the lower right, you can see that this is not as well defined in what's called an invasive carcinoma. They don't respect the borders of the air sacs, the tumor cells, and they can invade beyond the air sacs into the nearby tissues. So that's the distinction. So these are what the pathologists look at when we do surgery, for example, and we send them the tissue to analyze afterwards. And these are the types of things that they look at to define what type of cancer it is, how invasive it is, and the staging of the cancer that we're dealing with. Risk factors. The obvious one that everyone knows about is tobacco smoke. It is the leading risk factor. But again, it's important to note that not all lung cancer patients have prior history of smoking or exposure. Radon exposure is the second leading cause of lung cancer. Radon is an odorless and invisible radioactive gas naturally released from rocks, soil, and water. Radon can get into homes and buildings through small cracks or holes and build up in the air. And over time, breathing in high levels of radon can cause lung cancer. According to the U.S. Environmental Protection Agency, radon is the second leading cause of lung cancer in this country, and it's the leading cause among people who don't smoke. It can be more concentrated indoors. Breathing it in exposes your lungs to small amounts of radiation, and this may increase a person's risk of lung cancer. Also important to note is secondhand smoke, which is the third most common cause of lung cancer. And this is certainly very relevant because there are people who have exposure, for example, if their parents smoked while they were growing up. And even though any given person or patient hasn't smoked themselves, this exposure to the environment over years and consistently over time really has a comparable risk of smoke exposure and tobacco exposure in terms of developing lung cancer. So people should recognize that. It is not formally a requirement or eligibility for lung cancer screening, which we'll talk about in a moment. So anyone that comes to the clinic and says they have secondhand smoke exposure over 20 years, unfortunately, there are no evidence to advocate for lung cancer screening in those patients. But that doesn't mean that the risk isn't significant or shouldn't be considered when assessing a patient. So it's just something to keep in mind that some people might not recognize. Other exposures include occupational environmental hazards, that is substances like asbestos, arsenic, and other types of radiation. And so this is important more commonly when people have worked in jobs over many years that predispose to these types of risks. For example, asbestos, working in the Navy Yard, which is not uncommon, or asbestos in the form of construction and homework. These are things to think about in terms of lung cancer risk. And finally, family history, that includes genetic risk and hereditary risk. That can predispose and put any given person at a little bit higher risk than any other patient who does not have a family history or genetic history. And it's just important to note that beyond this, there are cases where we can attribute a specific cause. A lot of patients will come in and say, what causes lung cancer in any given patient, what caused their lung cancer. And unfortunately, despite our advances, we can't answer every question specifically like that. And there are definitely patients that present who have no smoking history, who have no family history, who have no occupational history. They're young, in their 30s or 40s, and they can have, for example, a little bit more commonly what's called an adenocarcinoma that's a result of an EGFR mutation. This is something we've seen before, and it just because you didn't smoke doesn't mean that you're not at risk for lung cancer, and it certainly can happen. So these are unanswered questions that we're still trying to work on and figure out. But that just goes to show that everyone has some vulnerability for lung cancer altogether. A little bit more about risk reduction. The obvious first recommendation is to not use tobacco products. Smoking cessation will certainly be very impactful in terms of accomplishing that goal. Now, if someone has smoked for 20 years or 30 years, for example, they carry that risk with them for the rest of their life, even if they stop smoking. So that 20 or 30 years of exposure to tobacco smoke, you will never be able to get rid of that. Well, so then what's the point of stopping? Well, the contrary to that is that you eliminate any further risk, because if you stop at 30 years, for example, that extra 5 or 10 years to put you at 40 years of smoking, that'll be a lesser risk of developing lung cancer as opposed to if you kept on smoking during that time. So even though it doesn't take away your old risk and that carries with you, it still stops any further increased risk from developing. Avoiding radon exposure. So there are some things that you can do. You can get your home tested for radon. It seems that this area in particular in Portland has at least the same amount of radon across the country, just doing a cursory search, and if not, it may be a little bit more, in fact. So there are some resources and links here. As you see, again, you can look at this if you want to get the slides following the talk. Where you can learn more about radon exposure and learn how to have testing done in your home if you'd like to. Avoiding secondhand smoke. We all have situations, whether it's being in public or with friends or family, where we're exposed incidentally to secondhand smoke, and you can do what you can to try to remove yourself from those situations if you don't want to have the exposure, and that will certainly go a long way over time. Avoid or limit exposure to cancer-causing substances. As we mentioned, if you recognize that there's an occupational exposure or anything else, you can stay vigilant about that and find ways to try to avoid any long-term exposure. And lung cancer screening, again, we'll talk about that a little bit more in a moment. Some general health maintenance recommendations. Now, these are general guidelines. It's hard to, again, attribute a specific modification to your lifestyle and say this will decrease your risk of lung cancer X%. It's hard to correlate these types of things very specifically, but in general, these practices will not only help reduce the incidence of cancer for lung cancer, but all cancers altogether. So that includes, of course, staying active and exercising. Actually, I was at a conference last week, an immunology and immunotherapy conference that focused on harnessing one's immune system to fight cancer. one of the PhDs mentioned that there have been studies and mouse studies that they evaluated where simply doing exercise mobilizes your immune cells outside of the lymph nodes and around the body. And that's important because these cells need to go around and survey and look around to see if there's anything harmful or abnormal in your body. And when you exercise, if you're mobilizing these immune cells, then that gives a better chance to see things like viruses or cancers or anything else that shouldn't be there to try to help heal your body. So there is a science behind that. Eating a healthy diet, of course, fruits, vegetables, whole grains, and that includes all your vitamins A, C, and E, and all your minerals, for example, zinc, potassium, selenium, and magnesium. You might have seen recently in headlines here and there about avoiding processed foods specifically. And unfortunately, in America, processed foods pretty much has its presence in every grocery store and is a mainstay of our diet. And what are processed foods? Processed foods are anything that are altered and packaged, and that includes things like your cereals, even the healthiest of cereals, but cereals, meats, cured meats, sausages, things that have added salts and nitrates. Basically anything that's not purely fresh, like vegetables and fruits. When you think about these Mediterranean diets, that's why those tend to be healthier, because that focuses on fresh produce and fresh seafood, for example. And so these processed foods, the reason why they're more harmful is that they have added ingredients to an extent that's not naturally found. And that includes sugars, that includes salts, and that includes fats. So it's hard, admittedly, it's hard in our culture in the US to avoid processed foods, because that is predominantly what we see, eat, and experience in the grocery store and when we're eating out and things like that. But if you all can do what you can to avoid that, that would help a long way. Drinking plenty of water and staying hydrated is always a good idea. And washing hands, of course, and we all know, especially in this age post-COVID, about reducing infection risk, and that helps with everything when it comes to bacteria and viruses and the resultant inflammation and injury to the body, which may have a contributory effect on cancer as well. Okay, lung cancer screening. So by definition, lung cancer screening is a test that detects lung cancer in people who are at higher risk but show no symptoms of disease. Low-dose CT scan is the only recommended screening test for lung cancer. And a low-dose CT scan has been shown to reduce lung cancer mortality. When people have no symptoms or tested to detect disease, that process is called screening. So if one were to have symptoms like a cough, for example, and then that prompts CT, that is not screening. So screening is in the absence of any signs or symptoms. And again, often symptoms of cancer don't appear until the disease has already spread. Screening for cancer increases the chance of being diagnosed at an early stage and lowers the chance of death from lung cancer. In general, early detection portends a better prognosis because it is easier to treat early stage cancers in general. And again, the only proven effective way to screen for lung cancer is a low-dose CT scan. There are official screening guidelines by the U.S. Preventative Services Task Force. And who should be screened? Well, these are adults aged 50 to 80 years old and who have a 20-pack year smoking history. So we define a pack year as the number of years any given person has smoked, multiply the number of packs per day on average that they smoke. So for example, a patient who has smoked for 20 years and the pack per day on average during that time has a 20 pack year smoking history. On the other hand, a patient that smoked 40 years, who smoked on average a half a pack a day, 40 times 0.5 is 20. Therefore, they also have a 20 pack year smoking history in the same way. In addition, these people also either need to be current smokers currently, or they had to have quit within the past 15 years. So if someone quit 20 or 30 years ago, they would not be eligible for lung cancer screening. But if they quit only 5 years ago, then they meet eligibility criteria. And once again, to stress, emphasize, they have no signs or symptoms of lung cancer. Where did these screening guidelines come from? There were a couple prominent studies. One called the NSLT trial, the National NLSC trial, rather, the National Lung Cancer Screening Trial, and another trial in Europe called the Nelson trial. So these initial results were published in 2011, and these guidelines from the USPSTF were published and recommended following that. Now, if anyone were to look further into these studies and the data supporting these guidelines, you will see that these recommendations have changed over time. So initially, it was actually age 55 to 75 with a 30-pack year smoking history, but recently, in 2021, the USPSTF amended these guidelines to show these current recommendations that you see on this slide. And they did that based on some simulation and modeling to show efficacy. But essentially what this does with the updated recommendations is that it expands the number of patients we can recommend this to by increasing the age gap from 55 to 75 to now 50 to 80, and decreasing the pack year smoking history from 30 to 20. So we'll be able to capture more patients who are eligible who can undergo screening based on these guidelines. The short story for these studies is that for the NLST study, they evaluated patients with the former guidelines in using X-ray or CT scans, and found that there was a 20% reduction in mortality in the patients who underwent CT scans using these guidelines. So it was clear that they showed efficacy with this study, the NLST study, and the European study, the Nelson study. So this shows a problem, though, with the current recommendation of lung cancer screening, which is that despite the strong evidence, we unfortunately had a challenge even as of 2023 about implementing these recommendations. So this is one example, and you'll see this is at the bottom is a citation, but a publication from 2023 that shows population level access and effectiveness challenges. And you can point your attention to the paragraph below, which will summarize what you're seeing in this graph here. Estimated levels of attrition and access to lung cancer screening for patients with lung cancer with U.S. population estimates. So estimates are based on projected 2023 U.S. lung cancer statistics. And this is the first column on the left. So agreeing with those numbers that I mentioned in the first few slides, this accounts for approximately 240 total cases of lung cancer in 2023 that are estimated to occur. Moving to the next column on the right, 50% screening eligibility among those patients with lung cancer. So of all the people in the first left-hand column, about 50% of these people would be eligible to have their lung cancers detected by these USPSTF lung cancer screening guidelines. So are they getting these screenings? Look at the third column. That's a 10% screening participation rate. You can just see visually that that third column is much lower than the second column. What that means is that these people in the third column, only 10%, or in other words, rather, the people in the second column, only 10% of those are getting the screening that they're eligible for and need. So we are not implementing the lung cancer screening guidelines for a number of reasons, and it's a problem. So these are cancers that could be detected. These are cancers that could be treated, but they're not getting treated or detected because of a lack of participation. If you move on to the fourth column, 67% of these people are still smoking among the screening participants. And if you move to the last column, 22% are adherent to subsequent screening cycles. So even of those people who are getting lung cancer screening, not all of them, and less than the majority of them, are sticking to annual screening thereafter. This is a big problem. I will show you another way of looking at this here. This is from the Centers for Disease Control and Prevention. You'll see by the citation at the bottom, it's a little bit outdated. It's from 2017, but nonetheless still relevant because the problem in 2017 isn't much different than the problem in 2023 again. So this was assessing the prevalence of lung cancer screening by state. And you'll see in bold here, the CDC used behavioral risk factor surveillance system data. That's self-reported data in 2017 in 10 states they looked at. And so if I point your attention to the flow diagram, in the first column, as we mentioned, lung cancer is the #1 cause of cancer deaths. Screening with low-dose CT can detect lung cancer early and save lives. But in the second panel, you see that more screening is needed because here in this study, 7 of 8 adults who met screening criteria did not report recommended screening. Okay, it's a little bit different than that 10% I just mentioned before, but overall, it's in the same ballpark in that basically only 10% or so, 10 to 15% of patients are getting the lung cancer screening they need, whereas the other 85–90% are not getting the lung cancer screening that they should be getting. Why is this happening? There's a lot of factors contributing to this, and everyone has a role in why this phenomenon is happening. It's that patients and people aren't aware of lung cancer screening. There's a lack of awareness. There's a lack of education. Primary care physicians, some of those primary care physicians also are not up to date about the efficacy and the screening guidelines. And there are some provider systems too that are very good about having a lung cancer screening program where multiple providers like pulmonologists, primary care physicians, surgeons, and oncologists discuss any given number of difficult cases that come through lung cancer screening. We do that here at Providence weekly. And that certainly helps to capture the patients that need this and to employ this detection. But without comprehensive programs, which are in a lot of communities, that also diminishes the ability of this implementation. So there are a lot of reasons. It's not one group or one person or one system. There's multiple levels of issues contributing to this. Nevertheless, this is where it stands in the current day and age. So again, to emphasize the point, in the third panel, healthcare providers and the patients all together should be discussing screening when appropriate. That is adults age 50 to 80. I crossed this out here because again, this is 2017 before the updated guidelines, but it is adults at age 50 to 80 with a heavy smoking history, that is 20 pack years or more, and who has smoked now or quit within the past 15 years. Lung cancer treatment. So I'll just give a basic breakdown of what we have today. Traditionally, conventionally, the 3 pillars of lung cancer treatment have been surgery, radiation, and chemotherapy or systemic therapy. Lately, as of the past 5 or so years, there's been really a surge of a 4th pillar now called immunotherapy. And that means harnessing the immune system in any way to fight the cancer effectively. And this has changed the outlook for lung cancer dramatically. To put in simple terms, the roles of all these therapies exist in the form of local therapy, that is surgery and radiation therapy. And local therapy means basically if the lung cancer is on an earlier stage and it's confined, to the lung, for example, we can use surgery or radiation to effectively treat the cancer. With lung cancer surgery, for example, it's a little bit different than other types of cancer surgeries because the lung has a functional role. So there's a certain limit to which we can take out the lung before it starts affecting one's breathing, as you can imagine. And if you put together the fact, again, that a lot of these cancers are in smokers who don't have healthy lungs, it can be challenging to figure out which of these patients are healthy enough and fit enough to undergo surgery for lung cancer because their lungs cannot handle taking out a certain amount. So there are some of these patients that have, despite the smoking history or any other history, good lung functions, and they're good lung function and they're good candidates for surgery. And other things that might contribute are their age, for example, or if they have other health problems like heart problems or blood pressure problems and so forth. And these all go into the suitability of surgery for any given patient. On the other hand, radiation therapy can often be used if those patients are not fit enough for surgery, and radiation can be effective in controlling the cancer. And so we have these discussions with the patients, and oftentimes in these tumor boards where we have all these different providers discussing again weekly about the nuances of any challenging cases, and when patients don't clearly fit into one treatment decision or another, we will all discuss these types of cases together. But these are basically the two options for local therapy. On the other hand, we have what's called systemic therapy. We call it systemic because these can be administered in the form of IV administration or a pill, for example. And it's systemic because it can be distributed throughout the body. These include, as everyone knows, traditional chemotherapy. We also have a category called targeted therapy, which describes medications that are focused specifically on their mechanism against common mutations or molecules found in cancer cells. And again, finally, we have what's more contemporary, recent, as of the past 5 or so years, immunotherapy. And in more detail, without getting into more detail, they can consist of any way of harnessing the immune system. That is, using an antibody that can be found in immune cells to turn these markers on or off to better activate the immune system. People are exploring vaccines. That's another form of immunotherapy. Vaccines, just like we have for the flu or COVID, people are exploring for cancer. Now, by and large, they haven't been effective for cancer as of now, but again, with this resurgence of immunotherapy, there are a lot of people who are exploring it, and they're showing some encouraging signs right now that we can't exclude it from a possible future new treatment. And another form of immunotherapy is called cell therapy, which is literally using any patient's immune cells and reinfusing them back into the patient as a living therapy. And so that's why this whole immunotherapy field is exciting. And I will say that for the first time, we can actually give the possibility of a durable response or a cure in some of these patients. We couldn't say that before, by and large, with chemotherapy or targeted therapy. It would just delay the inevitable. But with immunotherapy, even the late stage 4 cancers where the cancer is spread throughout the body, those even have a chance of having a cure with immunotherapy. And that's why it's so exciting now. Now, it's certainly not 100% of the patients that are responding in that way to immunotherapy, but at least it gives us the possibility, more so than the other historic treatments, of providing a cure. And that's exciting. So again, in general, these are the basic breakdowns of how we use them. There is some overlap. Without getting too granular, again, we can use any of these chemotherapies or immunotherapies together with surgery in combination to try to enhance its efficacy. And that can come in the form of before surgery or after surgery. But this is very much an area of exploration and debate, which is ongoing and controversial at this time. But even in the past 1 or 2 years, we've made significant progress. So I'll take a moment also to highlight what we have to offer at Providence in the form of research and clinical trials. And that includes studies and trials involving diagnosis of lung cancer, the treatment of lung cancer at all stages, and in particular studying cancer immunology and immunotherapy. So Providence Cancer Institute, and in particular Early Child's Research Institute here in Portland, we have particularly specific interest in immunotherapy and immunology here at the Providence Cancer Institute, and we're one of the worldwide leaders actually in this field. It's a very niche field, a very specific interest that not everyone, every institution has the capability or the interest to pursue studying, but we actually have a very high capability of studying that here. You might have heard in the news or in the New England Journal, one of our researchers, one that I work close with, Dr. Eric Tran, published last year in the New England Journal a case report about utilizing immune cells or T cells to recognize a specific mutation in a patient with pancreas cancer. And she had a 6-month durable response to the infusion of her own T cells that were modified to recognize this mutation called KRAS in her pancreas cancer. So we're really on the cusp of exciting things. All this just to say is that any patient that gets treated within our institute has an opportunity both to contribute to the ongoing research that we're doing here and to advance the knowledge that we have to help the greater cancer community, and to also be a potential participant if the need comes where the standard of care treatments are not working. And if we need to move on to potential options of clinical trials, we have many of them here. I will say just briefly that, again, I split my time between providing clinical care in the form of surgery to patients, and also I spend time in the laboratory studying immunotherapy for lung cancer. And my project is focusing on identifying these receptors in T cells that can identify the frequently expressed mutations in lung cancer, that is KRAS and EGFR, and patients that undergo standard of care surgery for early stage lung cancers. I've been able to collect some of those and study these T cell receptors in hopes of trying to find some mechanisms that may lead to a future treatment. The exciting thing about this project and also many other projects in our institute is that they're a form of what we call translational research. Translational research means that we can study the immune response in the lab in a way that directly translates to a therapy, a potential clinical trial, and the next generation therapy in a relatively rapid time. So we're working on these immune therapies, these cell therapies, and studying them in the lab in a way that can directly be implemented to open clinical trials in the near future, like the one that Dr. Tran has done, as I mentioned. And to have this quick turnaround from the lab to the clinic is really something exciting and fascinating that we're particularly good at here at Providence Cancer Institute. So you can find more at the link provided on the slide, but that's one unique aspect about getting care here at Providence Cancer Institute. One thing I do want to mention too, just going back a couple of slides, is that with respect to the screening protocols here, I mentioned this because it's something that everyone in the audience can benefit from directly. If you recognize that you or someone you know has the appropriate criteria here to be eligible for lung cancer screening, then certainly take the appropriate actions to engage in the screening protocols. So I just wanted to, I meant to mention that before. I didn't, but I just want to say that even you can have a direct difference, make a direct difference on yourself or someone you know from the information provided in today's discussion. So we're concluding the talk here. These are some more relevant resources relevant to our discussion today that you can look on your own time. and thank you for your attention and inviting me to speak and engage everyone in the community. This has been a great opportunity to emphasize Lung Cancer Awareness Month and inform everyone about where we stand now with current updates. So with that, let me know if you have any questions or want to discuss anything further. Thank you.
Thank you, Dr. David Chen, for a very informative presentation. Now we will be beginning the Q&A portion. During this time, we will also post a survey link into the chat box, and we ask that you kindly take a few minutes to fill it out. These will be used to improve future health across health talks and events, so we greatly appreciate your help. For the Q&A portion, we encourage you to turn on your cameras and unmute yourself to voice your questions, or you can also continue to type them in the chat box. Please note that we suggest you to continue mute yourself if you're not speaking during this time to minimize any background noise. Oh. Here is also a QR code link to the lung cancer talk evaluation as well. What you brought about immunotherapy. Is that currently in the works of possibly treating all types of lung cancer, or is it just to target specific kinds of lung cancer?
It depends on every lung cancer is evaluated with respect to specific subtypes. So, for example, again, the distinction between small cell and non-small cell is very clear and studied in different ways. So they group the patients according to the types. Even within non-small cell lung cancer, for example, we look at these mutations very closely to determine eligibility. For example, the EGFR mutated lung cancers as of late have been excluded from these trials of immunotherapy because they have not shown as much of a response, and or sometimes they show more toxicity. So this is an ongoing area of research, and there's no definitive recommendation, catch-all, be-all for all types of lung cancers right now, but it's really nuanced, and that's why we have to stay very up to date about the latest because it's changing constantly. So for us, it's even challenging, but yeah, not all lung cancers are the same.
Thank you to clarify that. Kind of a follow-up question to my question. You mentioned you specialize in immunotherapy with regards to EGFR mutation. I know that the people usually go through targeted therapy, but then that only has they usually only take it for about a year and a half before like a drug resistance or a mutation occurs. Would a patient potentially be available to join research regarding immunotherapy if they took the targeted therapy for a year and a half and failed it in a sense?
Yeah, so these are all going to be a very nuanced case by case evaluation. So I wouldn't be able to make any general recommendation based on that. It would just have to be any given patient that's in that situation. We'd have to just look at on an individual basis. I will say that given the trend I just mentioned, there are not a lot of trials for therapy that evaluate immunotherapy for EGFR mutated lung cancers. On the other hand, without respect to clinical trials or therapy, again, I mentioned earlier that I am studying one form of immunotherapy for these types of patients. So any trial for that is not open here right now in general. But that's why I'm studying it, because there is such a need for it. And we need to do better with respect to immunotherapy options for EGFR mutated patients. So.
Thank you. We also have some questions in the chat box. One question is, does smoking include all forms and products?
Yeah, actually, I was going to mention that. So, and I forgot to.
I suppose that refers to, for example, marijuana smoking or vaping, for example. So I would say that there's certainly not a insignificant risk of the smoke inhalation from anything else like marijuana, for example. And with vaping, even though it's not the same traditional type of cigarette smoke, we've definitely see it has effects on lung injury. And I will tell you, for example, just one or two anecdotes or stories from my training recently, a few years ago. There are young people, 18, 20, 22 years old, that are vaping that we saw really pronounced kind of horrific lung injuries that one or two of them I remember having to do operations on. So I almost feel like this vaping phenomenon is recapitulating the smoking phenomenon back in the 50s and 60s, where people didn't appreciate its harmful effects, yet everyone was doing it. And just because we didn't know it was harmful doesn't mean that it's not. And so it almost feels like the same phenomenon. People are going to vaping now and thinking that it might not be as harmful as cigarette smoking. Well, it's not as harmful only because it's so new and we haven't studied it, and there's definitely evidence that they can harm lungs. So I just caution people about thinking anything of the sort that it's less harmful, and it's just that we don't know. And I would actually caution that until we know, you have to assume that it's just as harmful. So I hope that answers some of that question.
Yeah, thank you. I think this next question kind of coincides with that one, but someone said when the USPSTF decreased the screening age to 50 from 55, could it be due to increased risk factors that start to pop up, like increased radion or chemicals like cigarettes or vaping?
Yeah, it's hard to, I'm not sure the details of the rationale, and I don't know even if we looked at it that they would specifically say, but again, we get a lot of questions about, does this specifically contribute to this risk factor specifically contribute to any incidence of cancer, for example? It's very hard to draw these types of causative and correlation type of things. But I would say that just kind of interpreting what it means to decrease the age from 55 to 50, it means that, look, people who are 50 years old who have a significant smoking history should have just the same amount of risk as someone who's 55, right? And you could even argue that for someone who's 45. I mean, there's it doesn't just stop at a certain time point or a certain group. Now you can get into the weeds a little bit and say, well, where do we stop that? And they've done the analysis to say, okay, there's a certain point where the benefit and the risk, the seesaw tips in the other direction in terms of detecting lung cancer. But it doesn't surprise me that the age has decreased from 55 to 50, because there's not a magic number or age where you suddenly go from no risk to increased risk, for example. So that overall, that's probably just in general the thought that's driving it. And with respect to the specific data that are contributing to that, we'd have to look at the USPSTF modeling and the publication that they put out. But it makes sense overall.
Mhm. Yeah, thank you. And then another question is, I guess, a personal. Well, since indoor smoking is prohibited, have you noticed any changes in the prevalence of lung cancer? Or I guess really since the changes to reduce cigarettes and all the promotion going on, have you seen any changes in the prevalence of lung cancer?
I think it's hard to draw big conclusions about that. One thing I'll say personally is that my career is very young and short right now, so I would be at a disadvantage to say that as opposed to someone who's been practicing for 20 or 30 years. But I wouldn't expect that there would be necessarily a decrease, because there are people older that are 50, 60, 70, 80 years old that had exposure to cigarette smoke back in the 70s and 80s when it was more prevalent indoors. And so that's, again, that historical risk and exposure is going to carry itself to the current day and age. So I don't know the answer to that, but I would imagine that it's not going to have any tangible impact anytime soon.
Thank you. Another question in the chat is, had the remission rates within 5 years of post-treatment / no signs of additional lung cancer tumor lesions been increasing in a positive way with immunotherapy in terms of patients who are treated?
Yeah, absolutely. Absolutely. And that's what's the encouraging, exciting thing. These are changes that are not going to happen immediately because the endpoint you're looking at is survival, for example. And survival, when you look at large population studies, you're not going to collect that data within a year's time, for example. These studies take years, 3 years, 5 years, 10 years to mature when you can get the full analysis of survival data. But over time, we are seeing, yes, an improved uh, um, efficacy of these newer treatments and people who are living longer. I think that goes for both immunotherapy and the latest targeted therapy. For example, the anti-EGFR therapies, they're generally not as durable as the immunotherapies, but the latest drugs called, for example, osimertinib, are certainly prolonging their duration effect compared to the earlier generations of anti-EGFR medication. So everyone's improving across the board.
Thank you. One of our audience members says, "Thank you for your answer, Dr. Chen. I wonder if they use models like the Markov chain to analyze current risk factors and lifestyles to find the age range from when a person who, for example, is a smoker and starts to transition from healthy to stage 1 lung cancer."
That's a good question. I don't know specifically the answer to that of using any, that particular method, but I think that these are all really good questions worth exploring for sure. But specifically, I don't know the answer to that analysis, but we're all looking at it in different and useful ways for sure.
What would, for someone who's newly diagnosed to lung cancer, what are some like lifestyle or nutrition um, recommendations that you would make? I think, at least I experience with my patients, one of the biggest things is what do I do now?
Yeah. Again, it's hard to make very concrete recommendations to say if you eat this or don't eat this, then it will decrease your risk by 10%. I mean, we just don't have data that are that specific, but it goes back to those general nutrition guidelines, which is it's going to be beneficial likely that if you maintain a healthier diet that is eating a balanced diet, fruits and vegetables, certainly less processed foods, because there's just increasing evidence that that's having a correlation with cancer and other illnesses, and sticking to low sugar and low salt and lower fat diets, all of these things all together, and sticking to fresher foods, less packaged and processed foods, I think altogether will help for reduction in cancer, reduction in any severity of illnesses overall.
Great. Okay. Thank you so much. Um, if anybody else has any other questions for Dr. Chen, please feel free to unmute yourself and express them or type them in the chat box. I'm continuing to read any questions listed in the chat box to Dr. Chen. We have another question in the chat box, or it was interesting to hear about the work being done specifically at Providence Cancer Institute. Is there anything else you would like to share about work specific to Portland or to Providence?
Sure. So we have a very strong research infrastructure here at Providence, Portland, for example, and anyone that is within our network. But I'll highlight our thoracic oncology group here. which is consisting of 3 surgeons, myself, Dr. Mary, and Dr. Dharampal, in addition to the medical oncologist, Dr. Sanborn, Dr. Brosnan, Dr. Ray Lee, and the radiation oncologist as well, of which there are many in our group. But we discuss cases at a tumor board every week. And also, we're very forward thinking about if anyone is eligible for any trials, that we have a whole host of them here, and we participate in them. We also emphasize, again, research or tissue collection at the time of surgery, because we have all the laboratories here and we have different investigators with different projects, not only with my project that I mentioned, for example, but other investigators in the labs here, and we kind of rotate. If there's any patients that are willing to contribute their surgical tissue specimen that would otherwise go to the pathologist, some of that can go to the lab. And each of these investigators here in the lab can use those to advance their studies and contribute to bettering our understanding of immunotherapy with respect to lung cancer and other cancers as well. So I think again, patients have a unique opportunity when they're treated here at Providence Portland and Providence Cancer Institute to contribute to the laboratory efforts in our studies, and also from a clinical perspective to participate in any trials if the standard of care treatments aren't working. Our group is very good about identifying and locating where these trials might be appropriate, whether it's here on site or nearby. We're very much in the know what the options are.
Thank you for that explanation. Are patients in the Portland area, if they're receiving care from a different institution, are they still able to contribute or possibly find out if they would be candidates for these clinical trials at Providence, or how would they go about doing that?
Yeah, so it'll have to be on a case-by-case basis, but so the short answer is that they would need to be evaluated by one of the appropriate providers, whether it's surgery or oncology. They would have to be seen in the clinic at Providence, and then we would figure out where they need to be directed to for any trial, for example. So we have had cases where specifically the insurance is not taken within our network. So these are some real world things that we have to deal with. But we have had exceptions, and we've had ways to get around that, because yeah, it comes to a point sometimes where only our network offers the participation on the trial, but the insurance is not appropriate. So we certainly have financial counselors and ways to get around that. But the first step is to try to get an appointment with one of our providers in the clinic.
Okay, thank you so much. Are there any other questions for Dr. Chen today?
There's one I see here
Oh,
from Kevin. With the
oh
patients you've
yes.
seen, does having increased risk factors for congestive heart disease tend to disqualify the patient from EGFR or immunotherapy? Yeah, so we have to, again, take into account all the patient's health history. We make a very comprehensive decision, taking all that into account for what treatment is appropriate. I will say that in and of itself, one thing like having heart disease or lung disease or whatever doesn't necessarily disqualify, but altogether, if you have one thing and another thing, that adds up. But it's a nuanced decision. We take all of those things into account. And that's why it's on us as the providers, the doctors, to look at every patient individually and tailor treatment according to them specifically. I will say that for those types of patients, that's more of the medical oncologist, not as much the surgeons like myself. That's like Dr. Sanborn, Dr. Brosnan, Dr. Lee, and they'll take a look at the patients for these immunotherapies or anti-EGFR therapies and see how fit and appropriate they are on an individual basis. But again, any complex patients, sometimes they span the spectrum of care, and we discuss any complex patients at tumor boards every week, which involve all the physicians, the surgeons, the pulmonologists, the radiation oncologists, radiologists, and the oncologists, and we put all our heads together.
Thank you so much, Dr. Chen, for presenting with us today and taking to the time to answer all of our many questions. It seems like this field of lung cancer is very specific to each patient and each case, but it seems like there's a lot of research done in the field to further the treatments and knowledge surrounding this field. And I think we all thank you so much for taking the time to kind of give us a little bit of insight into your field.
Absolutely. It was a pleasure speaking with everyone and answering your questions, and thanks for the opportunity. I appreciate it.
Um, Thank you. Thank you everyone for joining our health talk today and your wonderful questions. If you haven't yet, so please take, I encourage you to take our evaluation on this screen or the link in the chat box so we may improve on further health talks. Thank you so much, everyone. Thank you, Dr. Chen.
Thank you. Bye-bye.